So, Paul, you're a scientist. You have contributed to the field of cardiovascular disease risk factor. But as a practicing cardiologist, I'd like to hear your views about what is the role played by abdominal obesity in your practice as a cardiologist?
There's a big role. You know, abdominal obesity says it all. The problem is it's not even assessed in the cardiology field. It's not in the file. People are not measured at all, so it's underused.
So in you emphasize that abdominal obesity is not assessed, barely assessed in the practice of a clinical cardiologist, but in your own practice, what do you do? How do you integrate now all the risk associated with abdominal obesity in your own practice as a cardiologist?
You know, in the literature, it's pretty clear. This is the risk marker, so I don't weight people anymore. I just use waist circumference, and I target my intervention toward a waist circumference measurement. No, I'm not using weight anymore.
Now, obviously, in the field of cardiovascular disease risk assessment, you've been trained to pay attention to the quote-unquote traditional risk factor, the dyslipidemia, the hypertension, smoking, and so on. How do you incorporate now the risk of abdominal obesity in your own assessment?
We've been refining risk factor for years. So we've been measuring total cholesterol 20 years ago. We've moved to LDL and HDL, and now we're moving to ApoB, ApoA1. It's the same for body size or body shape, whatever you call it. We move from weight to BMI and now to waist. That's the way I saw it.
Now, obviously, you have convinced us that this is a powerful, modifiable risk factor. Having said that, it's a tremendous challenge in clinical practice to make patients lose weight. How do you foresee the future in the field of clinical cardiology if we want to tackle this new emerging risk factor?
Yeah, if you put aside weight and you use waist circumference, then your patient will feel that they achieve something when they bottom up their pants and saying, you know, I'm wasting waistline. So this is one thing. The other thing is when you lower the concomitant medication, diabetes pills, hypertension pills, by 1 or 2 centimeters of waistline, then you're in business. So people can see what they achieve aside from weight loss. So this is one thing. The other thing is residents and fellows are more used to new knowledge. It's like going femoral to radial into the cath lab. We've been using radial for years, for 20 years in our place. So now it's more commonly used, you know, elsewhere. It's the same with waist. So you should move from BMI to waist.
Now, you were one of the principal investigators of a long-term 3-year lifestyle modification program. Could you comment on that study?
Yeah, there's a lot of stuff that will come out from that study, but that study shows us that waist loss is better than weight loss, and that's the whole story.
How did you achieve that waist loss in that study?
We modulate not diet. It's not diet. We modulate food intake and we modulate physical activity. We do not prescribe such and such a type of exercise or such and such diet. Every diet works if you follow it. You will follow it for 3 months and then you're gone. So we modulate food intake, and that's people don't feel bad about it, and they make their own choice. Same for physical activity. They don't do exercise. They're being physically active. So it's an all new attitude.
So in closing, we've heard also that maybe we have been too technical in terms of our dietary recommendation, that the low-fat message was actually more confusing than anything. To your patient in a minute, what would be your key nuggets recommendations in terms of lifestyle habits?
Keep it simple. If you can achieve, don't change your diet. Don't change your food intake. First, try to achieve 10,000 steps a day. And after 3 months of that, then you will modulate your food intake by seeing a nutritionist. And then you will achieve great things.
Thank you.